Lone Hill. I'm an orthopedic surgeon here in Austin. I've lived here most of my life and have been in practice here at this location for about 35 years. And I'm in a group which now has 7 members. And then also more recently, like the last 2 or 3 years, we've merged with a larger group that's multi-specialty. But in this office, it's all orthopedics.
Okay. Can you tell us more about your specialty and then what an everyday deal looks like to you?
So in the last few decades particularly, there has been a strong trend towards subspecialization. And so now that there are a number of orthopedists in town who just do one area or one joint. And usually it will be one region, like typically it may be hand and wrist or shoulder and elbow or hip and knee or foot and ankle or pediatric orthopedics, a lot of congenital anomalies involved there, tumor, sports medicine, and other things. After my residency, which is the 5-year training period for after medical school for orthopedics, I then did another year of fellowship in joint replacement in London, England. And but I have not limited myself to just joint replacement since I returned. I do general orthopedics, you might say. So that includes fractures and ligament injuries, tendon injuries, ACL injuries, knee, hip and knee arthritis, and which often may lead to joint replacement, rotator cuff tendon problems, etc. In general, those more specifically, about half of the life of an orthopedic surgeon is in the office and the other half is in the hospital and surgery. And that can vary a little bit, but it's probably not more than 10 or 20% on either side. So I'll spend half a day or 4 hours in the office seeing patients, both for new injuries or follow-up on an old injury or change of a cast, or a post-op check, or a pre-op check if we know that they're ready for surgery and so forth. And then the other half of the day or half of my week may be going to the hospital and doing surgery or doing rounds after on a post-op patient, that sort of thing. Our day can be a little bit hectic and unpredictable, and in fact more so than some other specialties, maybe less than some others, in that we have a lot of emergency things. And so somebody may say, you know, my mother fell and we think she's got a broken hip, and get her in right away. Or somebody may come in they say, oh, my elbow's swollen, and it turns out it's an acute infection that will require drainage. So what you thought was going to be a 10-minute thing may turn into a 30-minute thing. So then the next patient on the schedule gets a little bit, irritated about why am I late and all that. My personal philosophy is that even if it means the next person has to be a little late, I'm going to devote the appropriate amount of time and effort to focus on that problem and hope that the next person will forgive me. So then at the hospital, that can involve a lot of the operating room, and it's actually a team effort that involves a lot of coordination, because the surgeon is not at all the only person in the room or involved. There are a number of technicians who sterilize the instruments, get the right ones out. There are literally thousands of different orthopedic instruments that are used, and there are different sets. And for a total knee to put in this kind of stuff will probably take 200 different instruments. Then there is typically a circulating nurse, which almost always is the RN, and she coordinates all the team members to get into their room at the right time. Then there's an anesthesiologist or a doctor trained in anesthesia, and then often a nurse, certified nurse anesthetist who will also do the anesthesia. But nonetheless, when it comes down to it, the surgeon, since I'm the one that, or the surgeon is the one who brings the patient to the hospital, where I decide whether they need surgery or whatever. Then I order the anesthetic, the instruments, and all that. I'm ultimately responsible for getting all that set up right and make sure it happens on schedule and get all the medications ordered. You have to know about the pharmacological stuff, pain management, antibiotics, anti-inflammatory things, coordinate that and get all the right equipment. And then afterwards, just doing the paperwork.
That's really interesting. So, what inspired you to be an orthopedic surgeon?
Oh, a little bit because I like working with my hands. I like projects. And also, one really nice thing about orthopedics is that in most cases, not every case, you can correct the problem back to normal. Mm-hmm. And in some other fields of medicine, you can kind of manage it along, maybe diabetes or maybe schizophrenia, but you don't really ever fix it. So in orthopedics, you have a fracture or somebody has a terrible arthritis in their knee, usually we can get it back absolutely all the way to normal. That's very gratifying to do that. It makes you feel good to have to see somebody limps in 1 month and the next day they're thanking you because their life is back. So.
And so what would you say that you enjoy most about your job, and what are like the biggest challenges that you face?
Well, I like the people interaction a lot. Of course, Austin's gotten to be a big enough city that sometimes I may see a person or patient a few times and then never see him again, or maybe for years. But on the other hand, it's also such that I get follow-up from a lot of people, and they say, oh, well, you fixed my trigger finger last year, and that went so well that now I'm back for my knee arthritis or my rotator cuff. And I like to spend a little bit of time finding out where they're from and a little bit about their family and what they do and that sort of thing. And some of that may come from the fact that before Austin, I lived in Alpine, which is a small town in West Texas, where most of the doctors were general practice doctors, and everybody knew everybody, so to speak. And when I was in high school, I worked at the hospital there, and so some of that has come back. He followed me to Austin.
So, are you still learning things in your new day-to-day job?
Yes.
Could you give us an example?
Yeah. Well, there's so many changes that it's almost hard to keep up. And it may be like computers and IT and that sort of thing. That, I mean, there's just so many different things happening all the time. There's a big focus currently about biologics, of which the simplest thing you may be aware would be stem cell stuff. But there are some bone graft materials like bone morphogenetic protein, which can help fractures heal. It's a very important chemical in bone repair. And how to obtain that and when to use it is still under investigation. Whether you can get stem cells by taking blood and spinning it down and using platelet-rich plasma is under investigation. And then all the hardware, astonishingly, is still improved. And I think sometimes patients are surprised by that, but cars get better every year too. So the materials that are used are are different. The designs are a bit different. It's not, even though it's been studied, and there are 1,000 different models of this total hip replacement. The designs still have some pros and cons, and so it's a constantly changing field. And then there's even some electrical bone stimulation that can be applied. And then another thing, to help put in a total joint replacement like this knee, the alignment in which it's put in is very important. And in general, this surface of the top of the tibia ought to be perpendicularly aligned to the center of the ankle. Well, sometimes, particularly in heavy people, it's difficult to tell where that is just looking at it on in surgery, and particularly when they're all draped out and you got all these sheets and all this stuff. It can be hard. So one technique to help align that is to use computer navigation, in which case put some little pins in as trackers, little fixed points, and there's a machine which has infrared readers, and then you attach this on, and then you feel real accurately where the ankle is, and then the computer will then show us exactly where the center of the ankle is, so that I can make these bone cuts real accurately.
What do you remember most from your undergraduate biology classes?
Well, I remember how the complexities, and it's gotten a lot more. I mean, the details about DNA and RNA and all that kind of stuff were, and the Krebs cycle were out there, but not really the detail that's known now, plus lots of other cycles that have come up. And I can remember wondering, not only in biology, but in a lot of other classes, like, why do I need this? Why, this, I will never need to know this. Well, it may take 10 years, but it will come up. And, transducers and infrared and uric acid metabolism, a whole bunch of stuff. It comes back, and maybe there's some new medicine that's invented, and you have to go back and say, oh yeah, this blocks this phase of metabolism, or this helps it filter through the kidney more efficiently. So I can remember those things a lot, both in undergraduate school and in medical school.
So you kind of talked earlier already about things that have changed in biology since you were in school, but of those things, which are kind of the most significant that are used quite frequently now?
Well, I think the focus on cell metabolism and biologics, you might say, is huge. 10 or 20 years ago, I might have said biomaterials, meaning polyethylene and chrome cobalt and titanium, and did I bring a ceramic head in? No, but sometimes we use a ceramic ball. Let's see if this will come off. This is actually modular and will disengage, but we hammer them on so hard so that it's actually a cold weld. So I would have said that years ago that that was biomaterials and mechanics, and now I'd say it's a bigger focus on biologics. And that includes pharmaceuticals and a whole bunch of things that we can do with injections, when to do that. Cost is an issue. I suppose another big factor that's been looming for a couple of decades, but really for focus now, is the cost of delivery of medical care. And I think a lot of people would be surprised how conscious doctors are about trying to do something cost effectively, that is, best result for the buck, and not to do something that's just, over the top, break the bank, either the Medicare bank or the patient's personal account. So some of the biologics. For example, if we did a platelet rich plasma, might just cost $200 or $300 just. But there's some promise that it can help speed up the healing of tendon injuries, in particular, like Achilles tendonitis or tennis elbow or extensor tendonitis. But that's still fairly expensive, you know. Now, to compared to other things, a few $100s doesn't sound like much, but you know, I would think it's a lot. If I went to the grocery store and they said this one's only $200 more than the next one, I'd say, I hope it's worth it. And then also there's a big focus about shortening hospital times. So for total hip replacement, and let's see, the first one I did was about 1976. We used to put the patient in the hospital a day or two before surgery so we could run some tests, make sure they didn't have a urine infection, that they didn't have anemia or whatever, low potassium, and then do the surgery, and then they might be in the hospital for 6 to 10 days. And now we'll do all the pre-op lab as an outpatient before surgery, admit them very early that morning, like 5 o'clock, do the surgery, and then they go home in 1 to 2 days. So that's obviously gives some cost savings on hospital time, but it also means a bigger team to do the operation and more expensive anesthetics and all that, but it's still cheaper than it was. And so sometimes it's frustrating to me to read how the cost of medical care keep going up, because I feel like I'm doing things a little more efficiently than I used to. Another example is in the knee, normal knee, and of course this one has artificial stuff in it, but between the femur and the tibia there's two little semilunar or crescent-shaped cartilages called the meniscus. And they take a lot of stress, and particularly can get torn easily with rotation or sports injuries. They're very common things you'll read in the sports pages that so-and-so athlete had a torn meniscus or cartilage. And so years ago, we would make an incision between 3 and 5 inches long and do that under direct vision. Now we can do that arthroscopically, which means typically 2 or 3 incisions about a ½ centimeter long. Are y'all into metric stuff? Yeah.
So much all metrics and physics.
Yeah. Anyway, 1/4 inch long perhaps, and use a little arthroscope, which is really a telescope that is the size of a soda straw and can actually see much better. It's almost like some of the spy movies where they snake a little tiny camera into the doorway and watch all the bad guys. You can see that sort of stuff. So we can see the bad guys in the knee and then use a little trimmer in there to trim it up, and do that in half the time that it took an open procedure, and they go home the same day, whereas 30 years ago they'd been in hospital for 4 days. So all that technology has evolved, and it's real interesting for me to think how the operations that I do now are hugely different than the operations that I did 30 years ago. It's all evolved, and it's, keeping up all these journals and books and going to classes, continuing medical education, and just learning from your peers, associates. We bounce cases off each other a lot, and it's like, what do you think about this one? You think I ought to do this or that? And I said, I think I'd do that one. And, anyway, learn from each other. And then learning from life and experience.
Do you show us about some of these things on the table?
Yes. So here is a hip or half a pelvis. And this is a right hip. This is the greater trochanter, where the three gluteal muscles attach. And this little prominence, I talked about different tuberosities or whatever had a function. This gives a lot better lever arm to help when you walk. It keeps your whole body from falling over. So the gluteal muscles are that. And then these are some of the real strong ligaments around the hip. And the hip is pretty accurately a ball and socket joint with a pretty deep socket. And so it is really stable usually, and it takes a lot of force for it to dislocate. And that includes also the real strong ligaments around the hip. Nonetheless, it has a lot of wear and force and friction and all that, and after a number of miles, and particularly if there's been some injuries, then the cartilage surfaces on the bone may wear away, and you've got arthritis and it hurts. On x-rays, that will show up as most typically as narrowing between the ball and the socket. And cartilage does not have much calcium or density to it. So on an x-ray, it actually looks like a little space, which may be 4 millimeters or so. And as it wears or thins out, a little bit like when you look at the tread on your tires, you'll see that gets narrow, and then it can need replacing. And when we do that, you have to know where all the nerves and arteries are and all that, so you don't go through those guys. Make an incision, part the muscles, cut the head or neck of the femur off about here. Long bones are a bit tubular, kind of like a pipe, and it's softer in the center with a thick outer rim. So we use some reamers and broaches and other things to real accurately get this put in place, get it lined up just right. Use some reamers on the socket that are a bit like cheese graters in their appearance. They're hemispherical, and make this socket a little bit bigger, and then put in the artificial socket and then a liner. The socket, or the metal in general, is attached to the bone in one of several ways. And the original ways involved using an acrylic cement called methyl methacrylate, or bone cement, to help anchor it in place. But with time, that can wear or work loose, and that's still a problem. So in the last years, there's been a trend to using uncemented components, in which these metal surfaces, which look like sandblasted material, is actually very precisely textured because it's known that bone cells prefer to grow onto a roughened surface that's about 400 microns in size. And so this is real specifically textured. We try to make it a press fit, a little bit like the way they used to make furniture with dowel rods and no nails. They would be all precisely fit together, no glue. And then when we've done that, get the sizes right, then fit it together and have a nice smooth surface. It is necessary for not only the muscles to heal, but also the ligaments that we've opened up to heal. So we always coach people to be a little bit cautious for a few months about extreme positioning, because if they got way up in some position, it could dislocate. Here are some pictures of inside a shoulder joint done with arthroscopy. And this is a little shaver. It's pencil size, but here magnified. This was actually a rotator cuff. Here's the head of the humerus, the middle glenohumeral ligament. And this is the tear of the rotator cuff. Here's some stitches in it. And that's my left shoulder. had a fracture, which is a little hard to see on this view, that started here and went way up here. And unfortunately, it went right into the middle of the joint. And of course, since the joint is the moving part, it is important to get it as smoothly reapproximated and fixed as possible. So they put this plate and these screws in, and that picture looks great as far as the alignment and so forth. But the cartilage inside the joint, which I said looks like just a little space, was so damaged that the joint collapsed and required another operation a couple of years later to fuse it. So here is side or lateral view 2 years later, where the tibia and the talus are fused together. And in fact, there was a little complication in the middle of all that, and it appeared that it had healed, but it hadn't, and this was a non-union. And so this patient went through a treatment with an electrical bone stimulator, which was a pulsed electromagnetic device that pulses fields so that you don't have to have wires. It's an external thing, but it induces electrical charge in bone cells, and they actually respond to that by growing.
So, last thing we're going to ask you is what advice you would give to an undergraduate UT student who's pre-med.
Well, I think it's worthwhile, even though there are a lot of changes. There are going to be more government and whatever changes coming up in the next 5 or 10 years, even more than scientific advancements. And who knows how that's going to pan out. But I think it's a very rewarding, gratifying field. It has a pretty good amount of job security. The work situation, so to speak, like whether you're in a group or you work for a hospital or you work for the government, VA, there are a lot of different variations in that. And in addition, different specialties, or even within one specialty, a lifestyle may be really different. In general, a dermatologist, and one of my best friends is a dermatologist, and he has a lot more of a 8 to 5 job. Doesn't have to get up at night for fix broken ankles or get up in the middle of the night to deliver babies. So there are a lot of different lifestyles, and you can limit your field to certain hours or just certain things if you prefer. If you want to just work with kids and all that, there's a lot of variability. So stay with it. You know, it is all important. You don't know what some of the things you're learning in undergraduate truly you probably will never encounter, but you don't know which ones. And there was a saying in medical school that semi-true, but and that is about half of everything you're being taught will prove in later years not to be an absolute truth, but you don't know which half it is. So you got to learn it all and realize that that's the best we know at the state of the art, and then be willing to change as more knowledge comes along.
Thank you very much.
My pleasure.